we might make a start. I think it's great to see such a big roll-up. Almost all conferences these days are so heavily dominated by PET, which is obviously great, but I think day-to-day nuclear medicine still revolves an awful lot around bone scans and cardiac scans, and I think they're a really important part of our practice and often don't get enough attention. I'd like to introduce, first of all, Professor Hans van der Vaal, who's known, I think, to most of the Australian audience and many of the overseas people. Hans has had a really long interest in sports medicine and currently works at Meadowbank, and he's going to be co-hosting, we're doing this bit with Mel Cusey, who's quite a renowned sports medicine physician, and they're going to talk. The title's The Changing Role of Nuclear Medicine in Sports Medicine in the Era of MRI. I wondered for a moment whether that might have been a misprint. It might have been the challenging role of sports medicine, but I think he assures me it really is the changing role. So without more ado, I'll introduce Hans and Mel to kick off the session.
Thank you. No. Firstly, I'd like to thank Gopi for inviting me to this, and I think there's deep irony in everything. I live and work in Australia, and I'm invited to talk at a nuclear medicine meeting in Australia by a British nuclear medicine physician. Is that funny? Probably painful. But what draws Gopi and me together is this man. This is Ignas Fogelman, who is a very close friend of both Gopi's and mine and was our mentor. I met Ignas when I was a junior registrar back in '88, and he became a very close friend, and I'm very sad to say his passing has left us with a great loss and a hole in bone scintigraphy, certainly. We do miss him, and he certainly was a very close friend of Gopi's as well, and I'm sure there are lots of people here who knew Ignas very well. So I'd like to dedicate this session to Ignas. Now, one of the disturbing things that spurred this talk on the sacroiliac joint mainly is I pulled out some of the data from Medicare for the last few years, and it's disturbing news in terms of nuclear medicine, which I'm sure all of you have suspected. And Steve Allwright and I were talking about this, that basically nuclear medicine is slowly dying. And this is perhaps a disturbing slide which shows you since 2008, the average study value of nuclear medicine has slowly fallen, while that of MRI has slowly risen. And this is in the face of a rising total number of studies being done and a rising general value of all the other imaging studies. It is disturbing that it's happening, and this is what's happening to our percentage of all of imaging in Australia. It's slowly but surely coming down. As you can see, from 2013, it's fallen. We were at about 2.83%, and it's now down to about 2.65%. So it's a disturbing figure. And this is just showing you the split up for the various states, that New South Wales does far and away more nuclear medicine than anybody else. The disturbing figure here is that 5 years ago, the average nuclear medicine physician in Australia did 8 studies per physician. Last year, it's come down to 6.2 studies per physician. We need to start thinking differently, or MRI is going to drown us. And I think we need a change of philosophy. I mean, I've started researching things that MRI can't answer anymore. And together with Mel, we've come up with a method of evaluating the sacroiliac joint. So this is just an outline of the talk. I'll introduce Mel. He'll talk about the clinical side of SIJ imaging. The reason we chose SIJ imaging is that MRI cannot answer the question. The reason it's important is that sacroiliac joint dysfunction is twice as common as disc disease as a cause of lateralizing lower back pain. And if you take one thing away from this, is that you can easily diagnose this if you put your mind to it and you look at the ancillary findings that you see on the bone spec CT. So that's the plan of the talk. As time is of the essence, I thought I'll hand over to Mel and he'll give you the clinical background. Press the laser there.
Good morning, everybody, and I also want to thank the organizers, Gopi, and I remember my only meeting with Ignas Fogelman, and we tried to explain this, and he really put me through the ringer until he said, now I get it. So, what are the mechanical roles? We're not talking about sacroiliitis here, we're talking about the mechanical role and the mechanical dysfunction of the SRJ. It is involved in up to 30% of non-specific low back pain. What we have learned in the sports medicine community and also in the World Congresses of Low Back and Pelvic Pain over the last 20 years is a lot of understanding on what it does, what the anatomical features required for the function and how to assess it. But until I came up with Hans and we worked on the SPECT-CT, there was no image modality that would give us an idea of the mechanical function of the SRJ. What are the functions from a mechanical point of view? One is to absorb torsion in the pelvis. And as I explained to my patients, if we did not have a little bit of movement, we would be walking like A2D2, and that's not a good idea. And in fact, if the SRJ doesn't move in elderly population, you end up with stress fractures of the sacrum. But then, on the other hand, you need stiffness to transfer load between the trunk and the lower limbs. Here in Australia, think about the scrum, for instance, or landings, pushing. You need to have a stable pelvis to transmit the load from up to down and vice versa. So you need a small range of motion, very small, but sufficient to absorb torsion. And flat surfaces are the best to transmit that pressure. So we need matching surfaces and we need bracing mechanisms. Let's go through them. As you can see on this, does that work? No, I cannot. Oh, hang on a second, here it is. That is a section of the SRJ, possibly at S2, and this is the synovial part, this is the ligamentous part, which is crucial in what we're going to be talking about. And of course, when you compress that, you have a solid ring. Then you have the ligamentous apparatus. And the crucial ones here are the interosseous ligament, and which is circled here, and the long dorsal sacroiliac ligament, which goes from PSIS to the tip, to the tubercle of S3 and possibly S4. Those are important ligaments that control, if you like, the small movement of the SRJ. Anteriorly, they are not so relevant. And then you have bracing mechanisms. And for those of you that are interested in radiology, these dark areas here that no radiology comments on, you can also see them on MRI as white, and those are significant because they are the fat degeneration of the deep fibers of multifidus, which is the first thing that goes when there is back pain at that particular level. But then talk about bracing mechanisms. We've got the lumbodorsal fascia, and this would be TA. If you have those things contracting properly, and the multifidus, when it contracts, it swells and puts that under tension, you can understand that that compresses the SRJ. That's why we talk about core stability in the rehabilitation and all these things. And finally, when everything works perfectly, the sacrum does this. It notates or bends forward, if you like. And that's important because if you have the sacrum notating, the sacroiliac joint becomes flatter, if you like, or more horizontal. Whereas if it goes back the other way, the anterior part and the superior part are going to take more of the load, and that is what we can see on the SPECT-CT, as Hans will explain later. Strategies to transfer load, to stiffen the SRJ. We call force closure when we talk about muscle activity. And we talk about form closure when we talk about shape of bones and ligaments. Neither of them is ideal. Certainly form closure would give you an A2D2 situation, if you like, the excessive stiffness, and force closure alone would not be able to do it properly. So that's a schematic way of what we call the self-bracing mechanism. It's a combination of the two. How do you clinically assess the SIJ? Like these human towers, you start at the base and you build it up. And that means take a history, do a clinical examination, and the imaging comes to confirm your diagnosis. Let's take you quickly through it. Typically, post-pregnancy or post-trauma, which can be falls in the buttocks. It can be in the sports situation, which is what I see mainly, repeated landings. I have seen it in hurdlers. I have seen it in gymnasts. I have seen it in basketballers or volleyballers when they land. Repeated landing on the same leg. And then you ask, what leg do you land on? Car accidents at low speed. You are at the traffic light and somebody hits you from behind. Foot on the brake, it creates a shear of the pelvis, and then 6 months or 1 or 2 years later is when you get the problem, because there is a lot of compensation strategy available, and the clinic presents when you run out of compensation. It's worse in loading situations, of course, because the load transfer is impaired. Standing, walking, running, negotiating stairs, sitting, getting in and out of the car, turning in bed, and particularly with females, urge incontinence and dyspareunia. What are the common clinical features? Buttock pain. So many people come and say, I've got a hip problem. It's not a hip problem. It can radiate to the thigh. Trochanteric pain, the so-called greater trochanteric pain syndrome, that's rubbish. You've got to work out why the greater trochanter is impinging on the trochanteric bursa. ITB tiredness is again a compensation mechanism. Gluteus medius piriformis, they are overworked and they fail. And you can have lateral knee pain. And pain in the groin and in the symphysis. Why? Those are the radiation areas where SIJ pain can produce. And many people come thinking they have sciatica, and it's not. If the pain doesn't get down to the foot, it's not sciatica in my book. Clinical examination. There are 4 evidence-based tests that can give you the clinical diagnosis. There are others. And then there is the literature that tells you the clusters of the compression and this and that and the other, which I don't think are all that useful. Unfortunately, imaging has not solved the problem until more recently, because X-ray, CT, and MRI, they don't give good results for mechanical function. They will be good for fractures, for tumors, for inflammatory conditions, but not for mechanical conditions. And if you look at the literature, it says that scintigraphy is useless. That was 20 years ago. Spexity is a new technique, which we are going to talk about. Hans will explain a bit further. What are the 4 clinical tests? The Stork test. In some countries, they call it the Gillette test. The posterior pelvic pain provocation test, the active straight leg raise, and the tender palpation of the long dorsal sacroiliac ligament that I showed you earlier. So we have coined the expression, because it's not dysfunction means that you don't know what it is, and pain is not a diagnosis. So we came with the idea of incompetence, like an incompetent valve, something that doesn't close properly, and we coined that that name, which has been published in the literature. Failure to transfer load optimally is, by definition, sacroiliac joint incompetence, and there are clear diagnostic criteria. History. We have called it positive 3 out of the 4 tests, just to give us, if you like, an increased margin of security. And the imaging that we'll talk about in a second. So, failure of load transfer, incompetence of the SIJ, is a valid clinical diagnosis that can be confirmed via appropriate studies like SPECT-CT, but at the moment is not particularly well known. Results. We've done maybe 2,000 patients or more. 80% improve with targeted exercise programs. They have to be very specific. Some of them require strengthening of the ligaments, and you can do prolotherapy, and now we're doing some research with PRP under ultrasound, which gives better results. And very, very few require an arthrodesis of the SIJ, and usually high-speed trauma. The imaging. The new information is available, as I have said, and then I'm going to leave this to Hans again. But remember, SPECT-CT gives us an insight into the biomechanics of the pelvis and also the compensation strategies.
Now, this, I've often talked about this, and I often get into all kinds of fights with people, so I'm really looking forward to some good fighting at the end of this. Because there's always somebody who wants to argue, and I'm very happy to argue. Now, what are the criteria? Now, increased uptake in the upper segments of the sacroiliac joint, that's mainly S2, is a highly non-specific sign. You get this in degenerative disease. As a matter of fact, there's literature on this from a guy called Alderink, who looked at a couple of hundred autopsies in males and females. 70% of women will have degenerative changes of the sacroiliac joint, possibly related to sacroiliac joint dysfunction, but no one knows. And about 40 or 50% of males will have degenerative change, indicating that there is some movement there. But the most important sign here is that you get increased uptake in the posterior soft tissue, specifically in the dorsal interosseous ligament of the sacroiliac joint. And we recently had dinner with Andrew Vleeming, who asked me to go looking for uptake in the long dorsal ligament. And I didn't even know where this thing was. And finally, I got out all the old studies and started looking, and you can see uptake. It's very superficial. You have to go a long way back posteriorly, get to the edge of the posterior superior iliac crest, and you can see the damn thing. And I've sent Andrea a whole bunch of these images just to tease him. And the other thing you do is, remember Mel was talking about the compensatory mechanisms, in bone scanning is beautiful for this. You see the sites of tendon uptake, particularly of the hamstrings, the adductors, the glutes. You can see and often get confused with trochanteric bursitis. I have to be careful because Steve was the first one to describe it. And you can see all the muscle insertions, and it fits beautifully with the theory of what's happening when you get disruption of the sacroiliac joint. These are the main, it's basically a standard bone scan. The only thing is I often get sent images from all over the place for comments and whether this patient has sacroiliac joint incompetence. The most crucial part of this is you have to acquire the study from the lesser trochanters up, because there's a huge number of findings that will add to your confidence in making this diagnosis, particularly of the tendon enthesopathies. So that's really important. The semi-quantitative analysis you should do roughly at the S2 level, and you can see that in the cross-section when you're doing these studies. So, as I said, we're looking for uptake mainly at the S2 level, the posterior soft tissue uptake, and just all the things I was just talking about with the muscles. And here's a normal SRJ, a bit hard to see from here. The key to this is the dark areas where the ligament sits. Normally, you shouldn't see anything there. And it's very hard to see. Sorry, and here, what you're looking for, if you compare it to the normal, is you get the ligament uptake here, and you start to see the uptake, the non-specific uptake in the upper segments of the joint. And you can see the ligament, if you compare the two sides, it's darker here with more counts in the dorsal interosseous ligament. And this sequence of images will show that to you even better. Sorry, it's a bit hard to. You can quantitate this, and this is crucially important, is that you draw a region of interest around it and look at the counts in the soft tissue. So this is the dorsal interosseous ligament, and you're looking for a count profile in these two areas. And obviously it's on the abnormal side. Now, Mel loved this idea that in the normal sacroiliac joint you get a dumbbell pattern. So that's the synovial part of the joint, and seeing you get this funny dumbbell, and you lose that dumbbell on the abnormal side because of increased uptake at S2. And the sclerosis, when I did the ROC analysis for this, the sclerosis is so non-specific, you get a 0.5 result. It's meaningless. And this is the only thing MRI sees, is you see bone marrow edema in the synovial part of the joint. It's not very helpful. And that's just putting it all together, just showing you, so you get the loss of the normal dumbbell, you get uptake in the dorsal interosseous ligament, and you can measure that, and you can see the increased uptake in the upper segment of the right sacroiliac joint for this. Now, we published this a few years ago, in about 2013 now, and Ignace insisted on us taking him through every single step of this thing so that he would understand what we were doing. And I'm happy to send anybody the paper who's interested in this. So the most important finding on the ROC, the receiver operator characteristic imaging, was the uptake in the dorsal interosseous ligament. We looked at 180 patients as controls, and none of them had that. Lots of them had sclerosis of the joint and increased uptake, but not in the dorsal interosseous ligament. No one had that. So it's almost a perfect result if you see uptake in the dorsal interosseous ligament. So these are the characteristics. We've done about probably 1,500 or 2,000 patients, and the patterns remain the same. Now, just to show you the adductor enthesopathies. So you see increased uptake at the site where the adductors insert. You can also see osteitis pubis, which is very common in the female patients. So you get increased uptake and mild sclerosis, or sometimes severe erosive sclerosis. And these are the other signs. I find, and most of the referrers like to see the coronal, where it's much more obvious to see the dorsal interosseous ligament. As you go posteriorly, you lose this gutter that you see on the normal side. And that's where the dorsal interosseous ligament is. So you get your adductor enthesopathy, which goes with it, and this is nearly 100% of people will have either unilateral or bilateral adductor enthesopathy, and you get a savage hamstring enthesopathy with this, as you attempt to compensate for what's happening as the joint fails to transfer load. The other thing, and the orthopedic surgeons have learned a pretty bitter lesson from this, is that because of overactivity of the gluteus medius, it goes into spasm, it pulls the hip into impingement. And sometimes people will present with a torn acetabular labrum, which you can actually see on the bone scan, as it is here. So you will get impingement with this condition, and it can sometimes be the presenting symptom. And Mel and I have seen lots of patients from the orthopedic surgeons, and they've learned not to operate on them, because you'll precipitate a disaster if you go and operate on the labrum. So SIJ is much more common than people think. It is in fact twice as common as disc prolapse as a cause of lateralizing lower back pain. You'll often, in our hands, trauma to the buttocks is a much more common cause than the postpartum disease, which is what started all this. So the other thing is, if you've got lateralizing lower back pain and an MRI that doesn't show neural compromise, it's SIJ to proven otherwise. And sadly, in our series, 75% of patients who had a normal MRI were given a diagnosis of psychiatric illness. So it is a really useful thing to diagnose. It's incredibly helpful, and it helps, and these are young patients. You have to remember that about 15 to 20% of pregnant women will have this, and 8% of them will be left with a permanent disability. They often come in with walking sticks, and it's a terrible thing to behold when you know you can treat this thing and get them better. You can get 80% of them better with directed physiotherapy. It's a crucially important diagnosis, and it's one we can make and nobody else can. So please do it. Thank you.
Well, we might hold questions till the end, except as Chair, I'm going to take the liberty of asking Hans one question.
Yes.
On your quantification, what difference do you need between your two sides before you call it positive?
About a 1/3 difference. It's highly significant.
For those at the back, there are still a few seats down the front if anyone wants to grab a spot in case they, for those who want to run, though, that's another matter. Moving on, I'd like to welcome Dr. Aram Pathpan, also from Royal Free in London, to talk on painful knee replacements, which I think is a difficult area for all of us. Even with the addition of SPECT CT, I suspect it's still difficult, but I'm sure he's going to shed some light on it for us. Thank you.
Thanks very much. Just like to start off by thanking the organisers for inviting me to speak to you today. It's a real privilege to be here in Melbourne to speak to you about SPECT CT and total knee replacements. So I'm going to cover some of the imaging protocols that we commonly use. I'm going to go through the reconstruction techniques that we use to image the knee. I'm going to take you through my way of assessing a knee replacement, and particularly focusing on how we can use the CT component to assess the component position. And then I'm going to finally show you some examples of knee pathology and what we can see with the SPECT CT. So the things I'm going to show you how we use the SPECT CT to look at patellofemoral degeneration, how we diagnose a synovitis, we look at component position in loosening, infection and impingement. So just to start off with the basics, we're talking about total knee replacements. We've been doing total knee replacements since the 1970s, and certainly in the UK we're doing over 70,000 a year in the NHS. The prevalence worldwide is increasing due to the ageing population. The most common indication for a total knee replacement is to relieve pain and improve mobility after osteoarthritis. As you can see from the image on the left, there's a femoral component, then there's a tibial component, and then there's a plastic spacer in between. And the plastic spacer is not visible on the X-ray or on the CT, but it's important. The knee isn't a simple hinge joint. There is translational movement between the femur and the tibia, and there's rotation as well. And part of the role of that plastic spacer is to allow that movement. The image here, the X-ray here on the right, also shows a replacement or a resurfacing of the patella. And that's also worth bearing in mind when you're reviewing your images. I'm just going to also mention sort of two different types of prostheses here. You've got a cruciate retaining and a posterior stabilized prosthesis. So in most patients who've had a total knee replacement, what happens is the anterior cruciate ligament, which is probably the most strongest stabilizer of the knee joint, is degenerate. But in some patients, the posterior cruciate ligament is still active. In those patients, the surgeon might consider a cruciate retaining prosthesis here on the left, and you can see that there's a notch in the femoral component, which allows for the posterior cruciate ligament to pass through. In patients who've got a degenerate or inactive posterior cruciate ligament, there is you can have a posterior stabilized component. And in this case, you've got a keel in the plastic spacer, and you have this box section here on the femoral component. When you look at the X-rays, you can tell the difference because you've got the box section here on the posterior stabilized, whereas the cruciate retaining doesn't have that box section. So how do we image the knee prosthesis? So we do a fairly standard 3-phase bone scan to start off with. So we'll do dynamic images and blood pool phase imaging, and we also do a whole body planar image. And the whole body is useful because it looks for sites of referred pain, so it allows you to assess the spine, allows you to assess the hips as well. And then finally we do a SPECT CT. This is a slightly old protocol from an older camera, but the principle is very similar. It's a pretty standard SPECT acquisition. The take-home message from the CT is go for thin slices, use an overlapping pitch. So we're using pitch of 0.65, got a nice high quality scan. Use an extended Hounsfield scale. and I'll explain why that's useful in a bit. Use a slightly higher KV to overcome some of the artifact from the metalwork. When we do the SPECT-CT reconstruction, one of the things is we try and reconstruct the images relative to the anatomical planes. So our axial reconstructions are parallel to the tibial plateau. Then we do a coronal reconstruction, which is actually parallel to the femoral condyles. And then our sagittal reconstructions are perpendicular to the coronals. We also do a small field of view. So when we do a SPECT-CT, we acquire both knees at the same time, and we do a reconstruction that includes both knees. However, we do a separate reconstruction with a small field of view just over the knee that we're interested in, because that gives us better detail. And this is an example of how using a wide Hansford's, extended Hansford scale can improve the image quality. When you use a standard Hounsfield scale, the cutoff at the top end is 4,000 Hounsfield units. So you can see in the image on the left, you've got a lot of streak artifact, and you can't really see the detail in the prosthesis itself. When we use the extended Hounsfield scale, which in most scanners will just be a tick box or a setting that you just need to change, immediately you've got a maximum Hounsfield units of 40,000. So you get much more detail. You can see that grayscale in the metalwork. And that will allow you to assess the prosthesis in more detail. Also, when you're reviewing your SPECT-CT images, you could consider using thicker slices. Although that you lose some of the resolution, you overcome some of the issues with the noise. The other thing that's slightly different about the way that we do our knee replacement assessments is that we look at the component position. So what we do is we do extended topograms. The basis of this is that we're trying to assess the component position of the knee replacement relative to the mechanical axis. So the mechanical axis is a line drawn from the center of the femoral head to the middle of the tibial plafond. And that's the weight-bearing axis. That's where the load of the knee and the knee replacement is going to be aligned to. So this is a modification from the Perth CT protocol for the knee, and essentially does the same thing except for the fact that it's a lower dose because we're just using topograms to assess. And from this, we can assess the varus and valgus angulation of the knee prosthesis. We can assess whether there's flexion or extension of the femoral component, and we can assess the tilt of the tibial component. So this is just the protocol that we use for our topograms. The only thing I'd sort of draw your attention to is the fact that with the lateral, it's really important that you ask the patient to flex the contralateral knee so that you get that out of the way when you can assess the knee that you're interested in. And obviously, if you've got a patient who's got bilateral knee replacements, you need to do 2 lateral topograms with the contralateral knee flexed. So what do we do with this information? Well, when we look at the when we look at the lateral topogram, we can assess things like the tibial slope. A normal knee prosthesis, the tibial component should be angled slightly posteriorly by about 3 to 8 degrees. Okay, this allows for adequate flexion of the knee without it impinging. However, it's important to measure that, because if on a long length image like the topogram or on a CT, because what you're looking for is to ensure that the tibial component is either not straight or not anteriorly angled, and you'll see some examples of why that can affect the uptake. The other thing we do with the CT is we look at the rotational component position. Now, this is actually the CT is the modality of choice for assessing rotational component position. It's something that's very difficult to assess on plain films, and so that's what we do routinely. The femoral component can be easily measured. You draw a line across the posterior aspect of the femoral prosthesis, and that's relative to the transepicondylar axis. The tibial component is slightly more complicated, and what I've done here is I've shown you an image where we've overlaid the tibial component overlying the tibia on a separate slice at the level of the tibial tuberosity. And what you're doing is you're measuring the rotation of the tibial component relative to the tibial tuberosity. So what can we diagnose with SPECT-CT and when we're looking at knee replacements? Well, this is an example of a synovitis, and to be honest, you don't really need a SPECT CT to be able to diagnose this, but you'll see on a dynamic image and a blood pool image, you'll see increased blood flow in the synovial. You'll see that's a reflection of the hyperemia. On the CT component, you might see a joint effusion, you might see some thickening of the joint capsule, but typically you won't see any abnormal uptake in the bone. So what we'll see is increased uptake on the dynamic and blood pool phases. It conforms to the joint capsule. On the CT component, we might see thickening of the capsule, and we might see a joint effusion as well. And the causes are multifactorial. Infection is certainly a cause for synovitis, but probably not one of the more common causes that we see. More commonly, it's related to polyethylene wear, ligament imbalance, and can be related to arthrofibrosis, which is a sort of a fibrotic process involving the capsule itself. And that's what we're seeing on the CT. Loosening of the knee prosthesis is probably the most common indication for the SPECT CT. So what is loosening? Well, loosening actually is just mechanical movement of the prosthesis. It's multifactorial, and the easiest way to actually make a diagnosis of loosening is to look at the baseline plane films. If you've got historical evidence of migration of the prosthesis, then you don't need to do anything else. You know that the prosthesis is loose because it's moved. Unfortunately, we don't always have the luxury of having the old imaging or baseline imaging with which to compare with. And what are the causes of loosening? Well, I've listed three here. One is poor positioning of the prosthesis initially. So it could be that the prosthesis wasn't inserted in the correct alignment to start off with. It could be related to material failure, either related to the polyethylene spacer or to even the metal itself. And the other cause can be a reaction of the bone to any component of the prosthesis, resulting in osteolysis. And it's these three things that we need to bear in mind when we're assessing a knee replacement and looking for loosening. So SPECT CT is actually very good because it can help us differentiate infection from aseptic loosening. SPECT CT has a high sensitivity and specificity for loosening. And it's really important just to look for very focal areas of uptake at the sites of stress of the around the prosthesis. So where are they? In the tibial component, you're going to get focal uptake around the stem and also the contralateral tibial tray. In the femoral component, you typically see focal uptake around the posterior aspects of the femoral condyles, and the lateral femoral component is particularly specific for loosening. The other thing to bear in mind is obviously knee replacements sometimes have the patella component resurfaced. And in that situation, you can get loosening of that component, which often shows as sort of irregular lucency around the patella. So what are the hallmarks of loosening? Well, the classic hallmarks is migration. And again, just comparing with previous imaging is the only way you can actually confirm that there's migration. But if you're seeing increased flow, hyperemia on blood pool phase imaging, then that's also a good indication that there might be some loosening. Loosening is more common in the tibial component compared to the femoral component, and you often get asymmetrical uptake when you're looking at loosening. As in this example here, you get a lucency at the bone cement interface or the bone prosthesis interface, and if you've got irregular osteolysis more than 2 millimeters, that's a concerning feature. The other real hallmark of loosening, and a good way of differentiating loosening from infection, is the fact that usually with loosening you don't get new bone formation. You can have quite extensive destruction of the bone with loosening, or aseptic loosening, but infection usually is associated with new bone formation as well. So this is an example of a loose total knee replacement. Here I've taken some thin slice MIP images and fused them with the SPECT. You can see there's very focal uptake around the tip of the tibial stem and in the contralateral tibial tray as well. And this is an area of osteolysis around the tibial component. In the femoral component, we see osteolysis around the posterior aspects of the femoral condyles associated with focal increased uptake adjacent to that. And this is another example where you've got this irregular lucency beneath the tibial tray associated with focal increased uptake. So very characteristic appearances for aseptic loosening of the tibial component. So again, just remember look at the patellar component. You can get loosening of the prosthesis. This can be due to fracture of the polyethylene component, can be related to infection, and it can be related to mechanical overstressing. So this is an example here where you've got loosening of the patellar component. You can see that there's a lucency between the prosthesis here and the bone. And in this case, it's actually due to a flexed femoral component. So you can't assess that just on the SPECT CT itself. You need to look at either the topograms or do a longer CT. Other things that can cause pain around the knee are impingement syndromes. The example on the left shows osteophytic growth around the prosthesis. The example in the middle shows increased uptake around the gastrocnemius insertions. And the final example again is the one you've seen earlier, where we've got focal uptake around the posterior aspect of the tibial tray, and that's related to a slight anterior tilt on this tibial component, which is resulting in posterior impingement as the knee flexes. So I've shown you some examples of patellar component loosening. What happens if the patella hasn't been resurfaced? So this is a slightly sort of controversial issue. Certainly in the UK, some surgeons will resurface the patella always at the time of surgery. Some will only resurface the patella if there's anterior knee pain at the time of the primary surgery. And I know this practice varies across the world. The sort of the concept of whether the patella is involved in knee pain is slightly uncertain. But certainly we can identify causes for anterior knee pain with the SPECT CT. SPECT CT can be very useful in identifying patellofemoral degeneration. We can use it to assess for patellar maltracking, and in the context of patients who've had a knee replacement, is useful in assessing patellar pain related to overstressing and can be related to the femoral component malposition. So when you're looking at a SPECT CT of a knee replacement, one of the things to look for is focal rather than diffuse uptake. Diffuse uptake in a patella after a knee replacement is a very non-specific thing, but focal uptake can be something that indicates pathology. So this is an example where you've got focal uptake in the patellar component. First thing when I see focal uptake in the patella like this is I ask myself, well, has the patella been resurfaced? Because you may not have that information necessarily on the request form, and the plain films may or may not be available. If you haven't got access to the plain films, then look carefully at the CT. Look for the peg holes that you might see in the patella, and that will give you an idea about whether the patella has been resurfaced or not. Then, characterize the uptake. Is it focal? Is it diffuse? And then look at the position of the patella. So this is an example where you've got patellofemoral degeneration, you've got focal uptake, and if you notice also the patella is slightly laterally tilted. So there is some patellar maltracking issue there. And actually this is the same knee in a sagittal plane. You can see this focal uptake is predominantly in the superior pole. Again, this is related to slight flexion of the femoral component and a low-lying patella. So this is contributing to that sort of patellofemoral degeneration that we're seeing. Infection of a knee replacement is the most common complication. Incidence is up to 2.5% in primary knee replacements, but actually up to about 20% in patients who've had a revision surgery. Infection occurs in they say about a third of infection occurs in the first 3 months, then a third in the first year, and then final third after about 1 year. And we often have great difficulty in diagnosing infection, both clinically and also with imaging. Part of the problem is the fact that with infection you're seeing an inflammatory reaction. Differentiating an inflammatory reaction that you get with aseptic loosening for infection can be difficult. However, we do notice that you get neutrophils in infection where you don't get that in aseptic loosening. The normal uptake patterns around the knee following a knee replacement are very variable. And as you might remember, I mentioned that so you get 2/3 of the cases of infection actually occur within the first year. So actually that's when you're getting remodeling of the bone, and we know that uptake in the bone can be increased just due to normal physiological processes. However, a negative bone scan can still be useful because it has a high negative predictive value for infection. The other thing to bear in mind is actually when we're looking at infections, actually relatively small numbers in studies that we're seeing both in research studies but also in clinical practice. We don't see that often infection compared to the numbers of scans that we do. This is a classic example. When you see sort of dynamic and blood pool images, you'll see diffuse uptake around the prosthesis. It's raging hot, and you start thinking, is this infection? What can the SPECT-CT add? Well, when we've got the SPECT-CT, we can see a lot more detail. So we can see that there's an intraosseous abscess. We can look for holes in the bone, the cloaca. We can look at the periosteal reaction. You can see a very nice periosteal reaction here on this CT, and that, to me, sort of rings alarm bells. That new bone formation that you don't see with aseptic loosening. And again, you see diffuse uptake rather than focal uptake. So it's a good way of differentiating aseptic loosening from infection. So what do we see? We see increased activity on dynamic and blood pool phases, which suggests inflammation. You see diffuse uptake around the prosthesis. You see a periosteal reaction. The other thing to look for, which you might see on the CT component, is soft tissue edema, soft tissue abscesses, and other ancillary features like joint effusions. Now, joint effusion is non-specific, but in the context of the other features adds to your diagnosis of possible infection. So just to summarize, I've been through some of the common complications of knee replacements that are visible on SPECT-CT, such as synovitis, aseptic loosening, infection, periprosthetic fractures, and patellar component degeneration, impingement syndromes. I think it's quite useful to use the CT to assess for lucencies and periprosthetic lucencies. I hope I've shown you how using the CT allows you to differentiate aseptic loosening from infection. And I'd encourage you to use the CT to measure the component position of your prostheses. That added value is how we can really improve the reports that we're providing our clinicians and hopefully add value to the patient management. Thank you very much.
Thank you, Aaron, for a great talk. I think a lot of us are going to go back and revise the way we do our CTs at the very least. And I think it was a really interesting and great talk, and looking at the research of it. I'd like to present that certificate from the World Federation. And could I invite all the speakers perhaps to come up and take questions? While they're coming up, there's two housekeeping notes. They've asked me to remind delegates to visit Matilda, the big kangaroo, and sign the World Federation Wall of Friendship outside exhibition door 8. Any questions? Uday.
Wondering what the difference between the dynamic versus the fixed is.
Do you want to use the mic, Uday?
I was just wondering what the difference between dynamic versus fixed lumbar fusion is.
That's an orthopedic question, the surgeon. but usually they say it's easier to do dynamic fixations because the chance of getting repetitive pain and repetitive surgery is less. Whereas if you do a fixed fusion, most of the loading goes on to one part of the spine rather than dispersing the load after the surgery. So therefore you got more chance for recurrent pain if you do a fixed fusion. But if you have a dynamic, the force is dispersed, so there's less likely to get into pseudoarthrosis and other complications.
Can you see that on the images? Is there a difference between some clues on the state CT or the dynamic fix?
Usually you will see some lucency if you're doing a dynamic one. Most of the time you will not see any associated increased uptake. Only if there is increased uptake, if the patient is symptomatic, then you give meaning to that lucency. But if there is no symptoms, without that you're going to overcall the diagnosis, because there is some physiological motion which is normal as a part of the dynamic surgeries. But if you're doing a fixed surgery, there is no physiological motion there. It's only alteration in the load.
I've got a question for Aram. Blood pools on knees, apart from the vascularity that's pathological tight around the prosthesis, the vascularity you see in the synovium, particularly the suprapatellar bursa, seem to see that even on normals for years after. Hips, you know, they say go back to normal over a period of time, which is debatable, how long that is, but knees seem to stay hot forever. Do you have any comment on that?
Yeah, I mean, I don't know. We do see it quite commonly. I don't know, I would say that it's necessarily normal. Certainly, I think our surgeons would consider that as a synovitis. Now, it's difficult and it's debatable as to whether that's necessarily the cause of the pain. But I take what you're saying. But it is a sort of an inflammatory process that's going on in the knee, and it is a well-described cause for, it can be a well-described cause for knee pain. So I think it's worth commenting on, and it is seen quite commonly, but it can be pathological.
But also what?
Yeah, go.
Because we work closely with my friend who was in Basel, who was an orthopedic surgeon, who was into more of standardizing the spec CT, giving some points to where the areas of uptake is. But what he says is, we should not think in only terms of biomechanical components of loosening. You should also think in terms of biochemical, because the type of prostheses you use, which will cause inflammatory reactions, because it is going to induce some neutrophil changes and other things over a period of time. And the second cause, he says, is whenever there is a knee pain post-surgical, don't immediately rush in terms of loosening or infection, because nearly about 25% to 30% of the patients will have patellofemoral degeneration, which is the commonest cause of pain post-surgically. So you should not go by the 1980s definition, infection and loosening. Beyond that, I'm not interested. So you need to think in terms of biochemical as well as biomechanical components, which is most important.
Well, look, I'd agree entirely. My impression has been for years that there's a lot more, whether it's metal reaction or
exactly.
what, there's a lot more inflammatory response in there, even in normals, than you would expect. I think it's much more common.
Just a question for you, Aaron. Do you have a rule of thumb for when the blood pool normalizes after a knee replacement? Or is it basically all bets are off, depending on the prosthesis?
Yeah, that's pretty much true. I think I have to say we don't really use that. For instance, we wouldn't use the blood pool in the early phases as something that's particularly useful.
I mean, say is the blood pool still abnormal at 2 years? And they've got a painful knee. What do you do with that?
So, I mean, it depends on where the uptake is on the delayed phase. So if we're just looking at blood pool activity and you're looking at increased blood flow.
But do you think that implies there is a problem there if the blood pool's still hot or warm at 2 years?
So, I mean, as a sort of general rule of thumb, I'd probably say about 6 months you would expect there to be some increased hyperemia. Then after that, it sort of tails off. But yeah, so certainly at 2 years, we wouldn't expect there to be any abnormal blood pool activity.
But what is more interesting is, in terms of when we were writing the E&M guidelines, the problem was to advocate infection imaging. But as a rule, even the pathological guidelines have come out. If there is a clinical question, if there is a knee infection, there's no role for imaging at all. Just put a needle, you'll get a diagnosis. There's no point in doing any imaging to assessment. That was one of the debate, whether to add it or not to add it in the guidelines. But what they say is imaging has got minimal role because of the biological changes. It varies from the patient's type of surgery. It can last for up to 6 months to 2 years. So any uptake doesn't mean pathology. That's the one thing. Is just look at it and you have to correlate.
Could I ask one other, or two parts to a question to Aram also, that we're seeing in our institution there's a lot more robotic surgery on the knees, and so we're seeing much, much less of the old typical stress reaction under one side of the tibial plate, etc. And seeing two things much more commonly. One is that anterior knee, anterior patella uptake, which I've sort of wondered is whether that's just a tight quadriceps patella tendon causing stress on the knee. And the other thing is, I was talking to one of the colleagues here, is lateral femoral condyle uptake just under the prosthesis, not right at the back, but under that edge. And I seem to keep seeing it even when it's, you know, the other knee that's the symptomatic one. Have you got any comment on this again? As you know, is it, how significant is it?
Yeah, so in terms of the patella, I think you're right, is that absolutely you do see issues with the patella extensor mechanism. And certainly anterior uptake can be related to just the quadriceps tendon and sort of the whole biomechanics of the knee as a result of that. I echo your point about the lateral femoral condyle. I've seen it a lot, and I can't explain it either. I tend to not, I certainly wouldn't call it loosening unless I see osteolysis that goes along with it. I think, as you say, you do see a sort of asymmetry of uptake quite a lot. And I suspect it's related to sort of the biomechanics, but
they need to tweak the design a bit more so that they unload that bit, or
I think it's very difficult.
Actually, the main aspect is if what we go by on the basis of just the uptake. If you talk to an orthopedic surgeon, if he sees the image, he will say the uptake is physiological or pathological, because after the surgery, it depends on how the patient walks. So he knows by doing the type of surgery, he knows if he says uptake in the medial aspect for the particular surgery, he says that's normal because that's how the patient is going to walk. So you need an orthopedic input. Otherwise, we are going just based on the uptake. We are again, orthopedics do that images. All he says is give me the image and he can make the diagnosis. But if you want to understand more about knee surgery, you have to go and look at the Michael Hirschman. He is one of the orthopedic surgeons. So he's got a, what do you call, as an algorithm. And he gives specific scores for each part. And also it's not just the type of prostheses, like whether, for example, Arun is going to talk about the hip replacements. It depends on the type of prostheses, whether it's a acetabular fixation or the, you know, how the fixation is. And based on that, the orthopedic surgeon has to have an input. He will be the person who's going to say whether the uptake is normal or abnormal. Otherwise, it's all purely biomechanical.
Actually, I was just going to put my clinical hat on. And the increase in the lateral aspect, it may also be because of the top of the prosthesis increasing a bit the Q angle of the knee, and therefore it would put more emphasis on the lateral aspect.
I think one of the things that's come out from all the speakers that were a real take-home message is communicating with your referrers, sports medicine physicians, orthopedic surgeons. The amount that you learn from what they're seeing and what they're doing so often can end up explaining why you're seeing something on the scan, and I think it's invaluable.
And vice versa.
Yeah, yes.
Yeah, the rule is when you take a selfie, involve an orthopedic surgeon.
So please go ahead.
Hi, Hans, hi. It's been 20 years. That was a fantastic talk, so thanks for that. I operate a nuclear medicine site in the middle of the Australian desert. It's a mining town. There's a lot of bad backs, and I haven't got an MRI scan to compete with. Yet I don't do a lot of bone scanning anymore on the back. And I have a lot of overseas trained doctors and a high rotation through there, so you've got to constantly educate. And they're entrenched with the radiation concerns. There must be something that comes through with the immigration centre or something. So I spend a lot of time trying to qualify that. I'm going to present you a paper to the OTDs, but the question I'm going to get is if structural imaging is fine, and we suspect clinically that there is mechanical dysfunction, why do the nuke, and we'll just go straight to the physio, just look at the patient 6-8 weeks later? How do I answer that?
Because there are other causes that you'll find as well. And let me tell you, on a number of occasions, especially where if they're working with machinery, they fall down something. Like this happened just day before yesterday. And for a year, they'll keep complaining and bitching about back pain. Right. And this is one of Mel's patients who was referred to him. And the guy comes in and he's got a non-union of a sacral fracture. And it's presenting with buttock pain on the right. I mean, and you have no idea what you're dealing with, because the MR guys just concentrate on the lumbar spine and they don't go down. And this guy it was a brutal scan. There was this gap about that big going all the way across his sacrum from the right side. And you will find some really nasty surprises when you do the SPECT CT properly. I mean, I found Ewing's tumors, I found all sorts of weird things that you never suspected. So it's well worth doing if you've got an unresolved pain.
There is another thing which is, I see many times people come to me, I've had the physio, I've got the core stability, and I'm still have the pain. Two things. One, if a physio after 6 or 8 weeks hasn't made a change, I say review or change physio, because they're not specific enough. The other thing is that with the SPECT CT, you see the compensation strategies, and that gives an idea to the physio other things that have to work on. Many of the times they say, oh, I'm doing work on my glutes and it doesn't work. Of course it doesn't, because the glute is overworked because it's doing the job of somebody else. So you have to
Which
go
you're not
back.
going to see on the other modalities. No.
And that's right.
Can I just ask about loosening? If a prosthesis is loose in one spot, isn't it loose in all spots, and you expect to see some diffuse uptake throughout?
So with loosening, what happens is the prosthesis is essentially rocking or moving, so particularly with the tibial component. And so where you see the uptake is actually where you've got the maximal stress and the maximal movement. And so that's why we get that sort of focal uptake, typically around the points where the movement is most and the stresses are most.
Mm-hmm.
And also it is important to know the fixation points, because you will see some uptake which is a normal at the fixation points. If it is alternate places, that's where the loosening will be. So you need to know the dynamics of how the prosthesis is fixed.
Well, if we haven't got any more questions, I'll close the session. Thank you very much all for your attendance, and thank you very much to the speakers for great talks.